Hello, everyone. Welcome to today's phlebotomy webinar on the evolution of phlebotomy. This is Sierra Tollefson, an education specialist for Mayo Clinic Laboratories. Our presenter today is Erin Pepper, Program Director in the Mayo Clinic School of Health Sciences Phlebotomy Technician Program at Mayo Clinic in Rochester, Minnesota. Just a couple of things to remind everyone of before we begin today. There will be a question and answer session at the end of the program. You can submit questions via the Q&A icon in Zoom. Please only use the chat function for any technical issues. Today's program is being recorded and will be posted to our website in a few weeks. And now I'll turn things over to our presenter.
Thank you. Welcome. Thank you for joining. I have been working in the field of phlebotomy for almost 20 years, and I've always wondered how it started. We see new innovations coming along frequently these days, but I've always wondered, where did it actually originate from? How did the field start to progress? So learning some of the background of the profession was really fascinating for me, and it gave me perspective on how important some of the advancements that we've seen over time actually are. So I hope you find this information on how phlebotomy got to where it is today as interesting as I did. I do not have any relevant financial relationships or off-label usage to disclose. It is my hope that by the end of this presentation, that you will learn how phlebotomy has come to be, how advancements have benefited the field with the introduction of safety devices and governing bodies that help to standardize the profession. So jumping right into some of the history, phlebotomy goes back as far as 1550 BC, potentially earlier, but this is where it's first documented, in ancient Egypt. Practitioners observed hippos in the wild. They would scratch themselves on various items to relieve an itch or some sort of discomfort. And from this, they thought that the hippos were bleeding, and that was providing them relief. When in reality, when hippos sweat, the sweat appears red, so it looks like blood. So the practitioners thought, well, if this works for hippos and makes them feel better, maybe it would work for humans as well. So they started the practice of bloodletting through scarification, which is making small cuts or scratches to allow bleeding to happen. This was documented at the time in their medical text, which is called the Ebers Papyrus. Moving forward in time to when Hippocrates reigned as the father of medicine, so between 300 and 400 BC, he taught others that all forms of illness and disease originated from a natural cause of some sort. He said that humans were made up of 4 humors that were also associated with other groupings of things such as the elements, so earth, fire, water, air, either cold or hot, moist or dry. They were associated with specific organs of the body, like the spleen, gallbladder, heart, and brain. Different age categories, so childhood, adolescence, maturity, and old age. And they were also influenced by the 4 seasons: winter, spring, summer, and autumn. So lots of groups of 4. So the 4 humors, the first one being yellow bile, was associated with an irritable disposition, heat and dry, the element of fire, summer, the gallbladder, and childhood. Black bile, associated with a sad disposition, cold and dry, the winter, spleen, and old age. Phlegm is another one of the humors associated with a calm and composed disposition, cold and moist, water, the season autumn, the brain, and maturity. And blood, being the last of the humors, is associated with a cheerful disposition, heat and moist, the element of air, season spring, the heart, and adolescence. So he said, if you were sick, some part of you was out of balance. And depending on where your pain was or where the illness originated would determine how you were going to be treated. So you may be given a diuretic or have vomiting induced or have blood removed from your body. And it was kind of during this time that bloodletting became a normal medical treatment for illnesses. Galen came along after Hippocrates. He was also a Greek physician. He believed in the four humors like Hippocrates did, but he felt that of the four, blood was the most important. And that makes it more important for us to have control over. He discovered that we not only have blood in our veins, but also in our arteries as well, as it was previously thought that our arteries were filled with air and not blood. So he believed also that our blood was created and used up. And if we didn't use it, the blood would start to accumulate in our extremities and become stagnant. So it needed to be purged. So even if you weren't ill, at some point you'd have to have your blood expelled so it wouldn't all become stagnant. Galen tried to make bloodletting as easy for everyone to do at home instead of needing to go and seek medical attention for this. So he created a do-it-yourself guide based on many things. So it would have things about like your age, the weather, your weight, where you were physically located at the time. And then you would use those instructions based on whatever ailments you had and whatever symptoms you had, would then tell you how much blood to eliminate. Hence saving you a trip to the doctor. You could do it yourself. When we got to the Middle Ages, bloodletting was really becoming even more popular as medical views were being exchanged all over Europe, as transportation was starting to get around, word of mouth and this sort of thing. Ideas were exchanging. So with the popularity came some regulations on bloodletting. Not in the way we regulate things today, not to make the practice safer or to have accountability if things go wrong, but it was regulated by the religion of the medical practitioner. So they decided that there were better days for bloodletting based on holy days or the phases of the moon or where the earth was in alignment with other planets. So in my mind, this would be comparable to having your blood drawn on a certain day based on your horoscope. Moving to the 19th century, bloodletting was still happening. Your physician would recommend it, but then you would actually go to the barber to have it performed. Barbers were part of the Surgeons Guild, but they could only perform certain procedures. They could perform bloodletting, wound surgery, cupping, leeching, shaving, tooth extraction, and enema administration. So kind of an express care, if you will. This is where the traditional red and white striped barber pole comes from. So the pole would represent the rod that was squeezed by the patient to promote bleeding, red for the blood, and white for the bandages. They initially used them as a tourniquet, and then once the bleeding was done, they would wrap them, use it as a bandage. These poles would be posted outside barbershops, so it was easier to find when you were out and about. At about this time, they also expanded the menu of how you could have blood removed. So one of the first things that was really popular was leeches. So in the 1830s, the French imported about 40 million leeches a year for medical purposes. Paris alone used as many as 6 million leeches during this time frame. So throughout the early decades of the century, hundreds of millions of leeches were used by physicians throughout Europe. They would place them on the patient, and once they drank their fill, they would just fall off the patient, and then they knew they were done. Leeches are still used in medicine today. Their saliva has a form of anticoagulant in it, and they're used in reconstructive surgeries and some other things, but no longer for the purposes of blood collection. Cupping is another method. It was typically used after bloodletting to remove any air from the incision site. Or they would do what is called hot cupping, where a warm cup was placed on the skin to bring the blood to the surface, leaving a bruise, and then they would sever the capillaries with a fleam or lancet and allow the patient to bleed. Cupping is still used without the slicing of the capillaries to help increase circulation and release harmful toxins. And this probably most recently had attention brought to it during the Olympics, where we witnessed many athletes, most notably swimmers, with circular bruises all over their back and chest from having cupping treatments. Scarification, so using superficial vessels with a syringe or spring-loaded lancet. They also had different devices with gears and blades that would snap and pierce the skin, really some scary looking devices. And this would probably be comparable to capillary collection today. Venisection, so using a lancet or fleam to open a vein, usually the median cubital, and probably for the same reason we choose it today, because it's easy to locate and relatively close to the surface. And arteriotomy, an artery was punctured, which of course we still do today as well. But during this time frame, they typically only used the artery that's in the temple, which is not typically one we use today. The uses of bloodletting expanded during this time as well. So it was kind of a go-to prescription for anything that ailed you. So from things like indigestion, if you had acne, if you had smallpox, insanity, they figured it was guaranteed to make you feel better. At one point, they even compared this to a woman's menstrual cycle. And they said that once a woman started to bleed, her disposition changed, often for the better. And at this time, that was all the proof they needed that this was an effective treatment. There was a French physician at the time too, Dr. Jacques Ferrand. He said that bloodletting could actually cure a broken heart. His recommendation was, we bleed somebody until the point of literal heart failure, and hopefully they would survive and thus be over the heartbreak. As a side note, it is said that our first president, George Washington's death, can be contributed to excessive bloodletting. In 1799, he came down with a really bad throat infection after spending the day riding horse out in the cold and rain. And his physicians bled him 4 times in 2 days. At that point, he was said to asked them to let him die in peace. Otherwise, his physicians probably would have continued to bleed him until he had no blood left. So in the 20th century, bloodletting kind of fell out of use. Basically, they found it really didn't work. It wasn't actually making people feel better, wasn't making ailments go away. But it was not an overnight change. So for years, there were physicians that were still practicing it, saying like, this is the way to go, and others that completely refused to utilize the method. We do still have a few diseases where bloodletting, although we don't call it bloodletting anymore, is used, and they're done by modern techniques, and it's called therapeutic phlebotomy. One of which is polycythemia, which involves the overproduction of red blood cells. In modern medicine, we're using the blood we collect to help diagnose illness, not as a treatment. So since we're not just bleeding a person to get rid of the blood, but actually need to contain it and run for testing. How did we go about collecting blood for testing procedures? Well, let's start with syringes. Syringes go back about as far as bloodletting, but they weren't used for blood collection. Primitive societies were actually using a form of a syringe for poison darts. So they would dip the ends of their darts into poison before firing them at their enemy, essentially injecting poison into their enemy. Ancient Romans were performing subcutaneous injections with syringes on willing patients with what they called a syringe. They kind of came up with the name. So how did that come to be? Well, Roman mythology tells a story of a beautiful nymph named Syrinx. She was pursued by Pan, who was the god of shepherds. He loved her, but she was afraid of him. So she kind of ran away, and to hide, she transformed herself into hollow reeds by the stream. Pan was so sad and distraught by this that he gathered the reeds and he used the tubes to construct a musical instrument. The panpipe, which is also called the Syrinx. Little is known about the exact mechanics of the injections that the Romans were using, but they may have named the hollow tube to inject the medicine the syringe, named after Syrinx, the nymph, because it was hollow like the reeds that she had turned herself into. In 1853, Alexander Wood, a Scottish physician, he was the first one to use a modern syringe for medical injections. Oddly enough, legend has it that his wife was the first addict to die of a drug overdose. So as you can see from these examples, syringes were initially used just to inject fluids into a person. It was many years later before they were actually used to draw blood. And there's not a lot of information out there as to when someone connected using a syringe to remove blood from the body. But once they figured it out, they were using a needle with a glass syringe. Glass is the material they had at the time. And then they would transfer it from the syringe directly into glass test tubes that would have fill marks kind of etched onto them. And then whatever anticoagulant was needed was added to the blood at that point. And then they would put a stopper on it to seal it to be transported to the lab. The tubes and syringes were reused, so they had to be cleaned between patients. So if you could imagine the wait times that would induce. The needles were also reused as well. And when they got dull, they were resharpened on a grinding wheel, but only when they got dull. So even if you've never drawn blood, this practice should really make you cringe because there were a lot of shortcomings with the process. If you needed more blood than just one syringe, it required multiple pokes. Dispensing right from the syringe into a tube, capping, filling, adding anticoagulant, all of that by hand. You're exposing yourself to splashes, spills, any of that sort of thing. Having an exposed needle filled with blood was also a hazard. And since it's going to be reused, you carried it around with you. So your chances of needle sticks and bloodborne pathogen exposures were really high. Then came vacuum blood collection systems. This allowed for greater safety, speed, ease of handling, kind of like what we see today. It's a double needle device. One end has the needle that enters the patient's vein, and the other end penetrates the rubber stopper on the tube and the holder. The vacuum in the tubes allows the tube to fill to the appropriate amount. We're going to talk more about tubes in a minute. The push button wing collection set, or butterfly, as it's commonly known, is kind of a newer innovation in the grand scheme of things, newer. This allows for attaching either an evacuated adapter on the end or a syringe, which then you could potentially swap out multiple syringes if you needed, without having to restick the patient. This provided us with more options where we can truly evaluate and assess what device is going to work best for the patient sitting in front of us, as not all veins or vein locations work with one specific device every time. In 1947, Joseph Kleiner invented the glass vacuum tube, which allows for the correct amount of blood to be pulled into the tube. So we were no longer hand squeezing blood into tubes. It was originally called the Vacutainer, but was later changed to Vacutainer by Becton, Dixon and Company. They needed to transport these tubes in vacuum tins that kind of look like coffee cans, but they did that so the stoppers wouldn't pop off kind of as they're walking down the hall. And then in 1985, Grainer Bio One manufactured the first vacuum tube in plastic instead of glass. And it was manufactured under the Vacuette brand. And not too long after that, Becton Dixon created their own plastic tube. They did that between 1991 and 1993. They called it the Vacutainer Plus. And the gentlemen that worked on that were Vogler, Montgomery, and Harper. It was kind of around this time that tubes became color-coded as well, depending on the additive or lack of additive inside them. And this is universal. So if you have a lavender tube of one brand, it has EDTA in it, just like a lavender tube from any other brand. And that's worldwide as well. So this ensures that regardless of what brand of tube we use, we're getting the same result when we test the blood inside it. And some of the agencies that regulate how tubes are made, basically to ensure consistency in design and construction, are the Food and Drug Administration, CLSI, Clinical Laboratory Standards Institute, International Standardization Organization, and the Medical Device Amendment of 1976 and the Safe Medical Devices Act of 1990. I'm going to go into these a little bit more in a couple of slides as well. Thinking of where this all started, just about anything would make blood collection safer than what it was originally. We now have safety shields on our needles, thus eliminating the need for recapping, and thank goodness we're not reusing needles. Some of these shields look different depending on the type of needle or even the manufacturer. Some slide to cover the needle, some snap over it. Sometimes the needle retracts itself completely into the device. All of these are designed to greatly reduce the chance of a needle stick exposure. Retracting lancets for point of care or capillary collections was another safety advancement. The caps on our tubes were designed to reduce splatter when they're removed, so less aerosolization. Moving to plastic tubes was also a really great advancement. Since tubes are round, they do tend to roll. If one fell on the floor, it was pretty much guaranteed to shatter. So not only were you exposed to blood, but also glass as well. So plastic was a great innovation there. The Medical Device Amendment of 1976, it followed a United States Senate finding that faulty medical devices had caused over 10,000 injuries, including over 700 deaths. This law applied reasonable safety and effectiveness safeguards to new devices, helped create pathways to regulate new devices, and this amendment also authorized the FDA to ban devices that they felt were too hazardous. In the early 1980s, sharps containers became available for use. This provides a puncture-resistant container for any of our needles or other sharps to be placed in. So this gives less threat of an exposure to others, not just the phlebotomist. So anybody else handling waste, housekeeping, nursing, any family members in the room, that sort of thing, not just the phlebotomist. Personal protective equipment, it became a requirement for employers to have on hand For each employee, they had to have enough to perform the job properly without having to reuse it or go without. This included items such as eyewear, gloves, masks, and lab coats. So during this time, for a phlebotomist that was going from doing their job without protective stuff like gloves, and then to being required, it was a big change. And many phlebotomists would actually rip the finger of their gloves off because their job was so dependent on them being able to trust what their feeling finger was telling them, and they didn't think they could trust it through gloves. Luckily, any new phlebotomist today is learning with gloves on, so it shouldn't be much of a struggle to utilize the proper equipment. The 21st Century Cures Act of 2016 was designed to help accelerate medical production development and bring new innovations and advancements to patients who need them faster and more efficiently, which is why I've put point of care testing on here as a safety advancement. It's more of a safety advancement for the patient. We're not having to do venipunctures on them as often for certain tests and can get results much faster. So if, for example, we took a diabetic patient that's in the hospital and maybe their blood sugars are they're out of whack and they need to have their glucose tested hourly or even more frequently. And if we didn't have the point of care testing for this, we would be performing a venipuncture every hour and having to send that blood to the testing lab to be tested. We probably wouldn't even have the results back before we needed to go back in and collect the next sample. And that's if the patient's not a difficult stick. So you may have to stick a couple times to even get that initial sample and get it to the lab. And so it might be even less than an hour before you're back again to try and collect that next sample. Whereas now we can do a simple finger stick, get basically 2 drops of blood because we're going to wipe that first one away and get rid of it, put the next one on our test strip, and we have results within a matter of seconds. And treatment, therefore, can be adjusted in real time. Advancements in devices and equipment was not the only area where improvements could be made. So coming up with ways to improve our phlebotomists, it presents in the form of certification. As of today, there are only 4 states that require their phlebotomists to be certified before being hired. They're Nevada, California, Washington, and Louisiana. I do foresee more states going to this requirement in the future. And there are certain institutions in other states that require certification, but that's based on the institution, not on the state. There are at least 10 different credentialing organizations in the United States. A couple of them are ASCP, the American Society for Clinical Pathologists, National Health Career Association, or NHA, American Medical Technologists, National Phlebotomy Association, and American Allied Health. There are other ones, and there are actually some other certificates that allow phlebotomy that falls underneath them. So some certified nursing assistants or certified medical assistants are also then certified as phlebotomists. In order to become a certified phlebotomist, there are some requirements that need to be met. They are having your high school diploma or equivalent and either completing an accredited phlebotomy program or working as a phlebotomist for at least 6 months full-time or longer if part-time. As I stated earlier, there's only 4 states that require this certification. So what are the other states doing? Some institutions hire people off the street and completely train them on the job. There are also many types of phlebotomy programs out there. Some are accredited or approved through a credentialing agency, meaning their program must meet specific requirements on what's taught and the experiences the student receives. There are also different phlebotomy programs that are not accredited or approved that people can take. If they're not accredited or approved, that means they don't have to meet all the standards, such as a required number of successful venipunctures or a certain number of clinical hours. So you could get a phlebotomist that took a 2-week online course and never stuck anybody, or somebody who was in a class where they only had to stick people they could recruit. So like I stated a moment ago, most institutions provide some on-the-job training as well. This allows for the phlebotomist to learn specifically according to that institution's procedures, which even if you're a certified phlebotomist, you're going to need to learn site-specific things once you're hired to an institution. Since not all phlebotomists need to be certified, you can see the need for and the importance of regulating the field. In 2008, the World Health Organization Injection Safety Program met to consult for best practices for phlebotomy and blood collection. They did this to protect healthcare workers and patients. Some of their recommendations are that institutions should have some sort of training to avoid mishaps and poor specimen quality. They recommended to reduce blood exposure and accidental injury devices, with engineered safety devices and sharps containers need to be provided. Institutions should also keep track of accidental exposures and needle sticks and have support services that are available to the employee when these exposures do happen. And they should have posted somewhere in the institution what an employee should do in the event of an exposure. They also recommended that institutions need to provide free of charge to the employee personal protective equipment that are single use, fit appropriately, and enough to not require reuse. I've kind of mentioned this before, which kind of states how important it is that now it's also being recommended that it's implemented in institutions. CLSI, the Clinical Laboratory Science Institute, has created guidelines for use by the global community to help institutions know how procedures should be done properly. Their standards are the most widely recognized resources for continually improving test quality, safety, and efficiency, and they cover a wide variety of topics, such as quality management systems, lab basics, validation, and information management. Just a couple examples of guidelines: GP41, which is the collection of diagnostic venous blood specimens. This guideline actually walks you through the process of performing a venipuncture. They also have a guideline for training programs to know which aspects are considered essential to teach those coming into the profession. That guideline is GP48, Essential Elements of a Phlebotomy Training Program. These are kind of nice because if you're thinking like, hey, I want to start my own program, this gives you a starting spot to say, these are the guidelines of what you need to include in that. NACLS, the National Accrediting Agency for Clinical Laboratory Sciences, started approving phlebotomy programs in 1986. And in 2023, they are moving over to accrediting them. So it's no longer an approval process, it's part of an accreditation process. And NACLS is just one. There are other accrediting bodies out there, and they're based on whether they're actually accrediting the institution or the program, and whether it's national or regional. The job of these agencies is to ensure that educational programs are teaching according to the standards and best practices in the field in which they're teaching, and typically require communication between the program itself and the agency with documentation that they're complying with all the standards. The Occupational Safety and Health Administration, or OSHA, as most of us know it, which is also part of the United States Department of Labor, has a standard on bloodborne pathogens, standard 1910-1030. This standard has information on having an exposure control plan, So like was mentioned from the World Health Organization, OSHA is also helping with this as well. So to have a plan, having methods of compliance, engineering and work practice controls, PPE, regulated waste, housekeeping, information provided to healthcare professionals, record keeping and communications of hazards to employees, just to name a few. And as I stated earlier, reporting of exposures to bloodborne pathogens and needle sticks is a requirement, but institutions should also have in place a way for employees to report incidents that don't fall into those categories. Like if there's a misidentification of a patient, or if the quality of the sample is poor and what the reason for it is, such as quantity not sufficient, maybe the sample is contaminated or clotted or hemolyzed. Institutions should also have something in place to report when there was an issue with a patient not treating staff appropriately. Just because they're a patient and they're not feeling well does not give them the right to treat medical personnel inappropriately. And these instances should be documented. Standard operating procedures, or SOPs, they're going to be specific to each institution, putting kind of all of these requirements that these other organizations have come up with into writing as to how their specific lab is going to perform all of their procedures, step by step, and in accordance with those requirements and regulations. So these should be detailed enough so somebody new to the area would be able to read them and understand how did you do the job correctly. Keeping in mind, this should not be a replacement for initial new employee training, but they can and should be used in conjunction with that training. All employees should have access to the standard operating procedures in case they are questioning something, and they need to be reviewed and updated frequently as well. So why do we need all of this regulation? It's basically to ensure that shortcuts are not taken and everyone's safety is considered, not just the patient, but the employee as well. It also helps to ensure that we're collecting quality samples and our phlebotomists understand their roles and responsibilities. Speaking of roles and responsibilities, effective phlebotomists wear many hats and balance many roles in their work. First and foremost, a phlebotomist must be skilled in all aspects of blood draws. They should have the knowledge and skills needed to practice in a variety of settings with a wide variety of patients. The field of phlebotomy is always changing as we gain information about best practices and new tools or techniques that become available. A successful phlebotomist will continue to learn and adapt, always working to stay current on changes to procedures and to share this information with colleagues. Being a strong communicator means effectively receiving, interpreting, remembering, and sharing information. Phlebotomists are responsible for communicating with patients, their family members, coworkers, and other members of the healthcare team. You will need to use critical thinking skills to solve problems in ways that adhere to procedure. At times, you may experience a conflict and will need to develop skills to address root causes and how to de-escalate these tense situations. Using the resources available to you, develop the habit of being aware of risks to patient and employee safety and well-being, and kind of implementing that adage of if you see something, say something. In today's healthcare setting, there is often a heavy workload, and it's not uncommon for areas to be understaffed. This requires all staff to be efficient and effective time managers. Focus on working together as a team to meet our patients' needs in a timely fashion that minimizes any additional stress on staffing resources. I would also like to point out that the scope of practice for phlebotomists also seems to be ever changing. Some institutions have their phlebotomists just drawing blood, and others have them doing many other procedures, such as placing IVs, assisting with line collections, non-blood collections, such as handing out urine, stool containers, or performing swabs. Some phlebotomists perform sweat testing or ECGs and many other procedures. It's no longer a field where all you're going to do is one thing. So if we think back just to the beginning of this presentation, and we think about where phlebotomy originated from and all the advancements to get us where we are today, we can't assume that this is where the advancements are going to end. So where will the future take phlebotomy? Are we going to have robots taking our blood? I saw an article on this and it actually frightens me because I always just envision a huge sewing machine coming at me. Kind of lacks the whole personal touch. Will advancements in point of care allow us to run all testing off of a couple drops of blood? I really don't have the answer to any of these questions, but it just shows that we maybe have not met our full potential for what phlebotomy can be one day. And I'm definitely open to discussion on this at the end of the presentation. So in conclusion, as I just stated, we have come a long way from bloodletting for any ailment known to man to safely drawing a small amount for diagnostic purposes. Today, we also have many agencies and regulatory bodies that are here to ensure that we're educated, safe, and properly equipped to provide the best care possible to our patients. And just one last item, there's always been a value in blood for medical purposes, and I do not see that changing in the future.
Thank you, Erin. At this time, we'd like to take any questions that any of you have. Questions can be submitted through the Q&A icon in Zoom.
All right. And there are a couple of questions. Well, actually, one's just a comment. I guess there were not much education about diseases back when they were reusing the needles or resharpening them. I agree with that. Like I said, I was doing research and I found it really rather frightening, all the things that they were doing. And another question is, what major changes in phlebotomy since COVID-19? I can't answer for a lot of other institutions. I would say, at least here at Mayo Rochester, probably the biggest changes was in our PPE usage. We were always wearing gloves and eyewear, but now masks are kind of part of the everyday PPE usage. And I think there was a closer look at different isolation precautions for different things. And I get, to me, that's always a good thing. The safer we are, the better. So, but of course, if anybody else has anything to add to that, I can certainly put it in the question and answer.
Looks like that might be it for questions today. And with that, we would like to take the time to invite you to attend the 2023 Phlebotomy Conference, which will be held April 20th and 21st at the Hilton Hotel in Rochester, Minnesota. Please scan the QR code or visit mayocliniclabs.com/2023 phlebotomy for more information or to register. We hope that you can join us. Thank you for participating in today's phlebotomy webinar on the evolution of phlebotomy. If your question was not addressed during today's session, or if you have any additional questions, please include them in the evaluation. You may reference the link in the chat to access the evaluation beginning at noon Central Time today. Laboratory credit is extended for this program. Upon finalizing your evaluation, you will have the option to claim credit and print your certificate. If you had registered for this webinar and joined by phone only, please email us at mcleducation@mayo.edu if you do not receive the evaluation. As a reminder, this program was recorded and will be archived on our website in a few weeks. Thank you again for joining us for today's webinar, and have a great day.